Okay, thanks very much, Drew. So welcome everyone. Welcome to NHS Devon Clinical Commissioning Group's public governing body meeting for the 27th of May. We've got a number of guests, and we'll do introductions as we go through. And I hope that if you're a member of the public who's joining us or who listens in, that you'll hear us hopefully initially starting off by focusing on our population and how we work to get the best outcomes for them possible. And Naomi is here to talk about one aspect of that. And then some of the key issues that we need to be focusing on as a health system of Devon, and we'll be discussing those and making some key decisions which I think will impact our population and hopefully give them the best care that we can as a whole system. So thank you for joining us. What we'll do is we'll start with Naomi in just a moment. Naomi, rather than going through and introducing everyone, we've got a mixture of non-executive directors for the board. We've got our executives who lead on all the main things, the pieces of work that we need to concentrate on as a commissioning group. And we've got clinicians, a mixture of GPs, secondary care consultants, and allied health professionals and nurses as a team. So that's kind of the spread that we've got. And then if people have a comment or question for Naomi after she's spoken to us, if you can introduce yourself at that point, I think that would be really helpful. And we also have a number of people who are joining us for one of our later items who are key to the provision of our services in the Plymouth and West Devon area. So Naomi, thank you for joining us. You and I met in person not that long ago at Exeter Mosque, which was a really valuable time. But I know that you've been working really closely with the team here, both initially at engaging with the members of your mosque and their families, and then setting up a way in which we can get the COVID vaccine to them to try and make sure that they are as protected as everyone else in our community. So it's a chance for you to share your experience of that, really. I guess that's what we're here to hear.
Yeah, brilliant. Thank you for the opportunity. I should say right at the start, actually, it's been an absolute privilege working with the team in delivering the vaccinations at the mosque. You will all be aware that there is some discrepancy in terms of statistics for take up for the vaccinations from the BAME community, a term that I don't like using. But for the sake of clarity, that's what I'm going to stick with. I prefer to use heritage ethnicities, actually. But in terms of take up amongst the BAME community, it has been quite slow. And I was first approached by Sarah Ogilvie to see if the mosque community would be interested. And yeah, the mosque have been very privileged and honoured to have been able to work with the team. I think there is and remains some hesitation within the BAME community. And this it's a long-standing relationship almost, actually, with clinicians in some ways, because you will know that there are anti-vaxxers all across the spectrum. So it's not something which is unique to the BAME community. But within our Muslim community, there is some hesitation purely because of a lot of misinformation. People have a tendency to kind of believe stuff without verifying it on social media platforms and stuff. So that's been one of the bigger reasons why people have been reluctant to take up the vaccinations. And what we've been able to do with the help of this particular team is to give people solid information about what we know. So this is facts on the ground about safety. And so the vaccination isn't about safeguarding just yourself. It's also about safeguarding vulnerable people around you. So that was the kind of message that we'd given out to the Muslim community. I do have to point out that although the vaccinations took place at the mosque, but we were quite clear that this is open to the wider community as well. So if anybody wanted to give the vaccination at the mosque for whatever reason, even if they're not from a Muslim background, we would have been quite I I did find in my own experience with the Muslim community that there was this expectation that, you know, I can kind of call up the mosque and they'll be able to arrange something overnight. I think people are a bit unaware of the logistics that are needed behind an operation like this. But this was our first experience with Exeter Mosque. It was a learning curve. We've got on the 21st of July, we've got the second vaccination coming up for the same people that had the first vaccination. I've had conversations with people within the team but we're trying to get around logistics with the Pfizer vaccination, because we are now looking at the cohort that is quite young in age, and getting the Pfizer to the mosque can be a bit problematic. So it may be that some future vaccinations won't actually take place at the mosque itself, but we would still be able to support the team by getting the word out to people, helping with the booking system. So they might actually get the vaccination at a different venue, maybe not at the mosque. But in terms of looking forward, and when I say forward, I mean in terms of working, my understanding is that the vaccinations may slowly turn into what we know today as the flu vaccinations, where it has to be frequent as in perhaps once a year. And if that is the case, I and the trustees at the mosque, we've had this conversation with them already, they would be more than happy to accommodate and to have a day or a couple of days throughout the year where we can reach out to the Muslim community and ensure that as many people are vaccinated as possible. We've already been through the processes of informing people, not just informing them, but giving them facts that help them to make an informed decision. We can't, you know, that we can't we can't enforce anything on anyone, but we can give them information to help them to make an informed decision. And based on that, I'm quite keen in the years to come to be able to build up that relationship and keep it at a constant where we can offer the venue at the mosque for the Muslim community and the wider community indeed to be able to get the vaccination. But it does mean that we have to continue the conversation, the dialogue around why it's important to get the vaccinations, and to kind of try and break down some of the barriers that people seem to be facing when it comes to making the decision to take up the vaccine. But that's in a nutshell where we are at the moment. And it's also a glimpse into where I would like to see the mosque head towards. I'm, for those of you that might not be aware, Paul, you know, and Darren, you know that I'm actually moving from Exeter. I'm moving this Saturday. I will be coming back to Exeter Mosque for the 21st of July, because if I've given my word, then, you know, it's going to take place at the mosque. So I'm going to be coming back for that. But what I would like to see is for us to be able to actually set up a process where perhaps a year down the line, we are in a position to be able to say, yes, we've got X number of volunteers who will be able to facilitate a vaccination session at the mosque. So yeah, that's the aim, that's the target at the moment.
Naomi, thank you very much. And can I just say, from a personal perspective, when I came to visit, both yourself and Imam Ahmed made me feel really welcome. And we had a really useful and engaging discussion with both of you, but also with members of your mosque. So that was really valuable. And actually, to hear your Imam being very supportive of the programme, you know, obviously he is, you know, a spiritual influence for a large number of people in the area, but actually to have that support from a community figure like him was really valuable and helpful. In us, hopefully.
Yeah, I one of the positives that has come out of this is the media attention on the mosque, and it really was very positive. It really was really positive. I'm glad that the Imam really was on board, and his message was really strong. It was concise. It was very clear. And, you know, given the limited time that we had, I felt that it was a really positive outcome to the entire project, if you like.
And Andrew, I don't know if you want to come in, because we have our big figures of how many vaccines we deliver and the percentages, and they're all really high, but often it can hide some of those more reluctant communities or the harder to reach communities. And this is just one of a number of things we've done to try and capture those that might not be visible in the big numbers, but we are aware that are out there in the communities.
Yes, we are, Chair, and I'd like to thank Naomi as well for everything she did to help us get this off the ground. And I think one of the things, Chair, that I'd like to explore perhaps with Naomi outside is perhaps how we build on this to really engage as a service on a much more frequent and regular basis, an ongoing basis, with communities like Naomi's, because I think it shows when we do things like this and do it well, it has a major impact. And so I think this is just part of our journey. And we obviously got a report later on, Chair, haven't we, that we commissioned to look at the experiences of people from, it's termed, Naomi, you won't like this, from BME communities, but recognising how you now refer to it. But we've got quite a hard-hitting report, haven't we, later on, that shows that we've got a lot of work to do to improve the experiences of people from such communities, whether they work in the service or whether they receive the services that we provide. So I think it's start of a journey, but with support from people like Naomi, I think it's been a fantastic experience and a big learning experience for all of us.
Brilliant, thanks, Andrew. Any questions or comments for Naomi? Alison.
Thank you, Chair. Naomi, thank you for that. One of the things you said was about the importance of getting information to people. And can I ask, initially, were we getting the right information out to the Muslim communities, or is there anything that you can easily identify that we could do differently in the future?
I think, to be honest, Alison, I think the information is readily available out there. The problem that we actually face is that there are two distinct problems, as far as I'm aware. Muslim communities tend to be made up. So, for example, in my family, the move that I'm about to make, typically there's going to be 3 generations in that family, because I've got my granddaughter there as well, and I've got my kids. Within those households, I mean, I'm somebody who I believe that I'm quite well informed. 2 years ago, I would have had my parents with me, who would have been heavily reliant on my opinion. Now, I like I said, I feel that I'm an informed individual, but not everybody is the same. What often happens within the Muslim community is that families will, especially with the older generation, they will be influenced by their younger generation within the family. And if those individuals are people who have hesitation with the vaccination, it doesn't go down well. It doesn't go down well because their hesitation, there might be a valid point why they are hesitating. You know, it might be something to do with their own medical conditions, pre-existing medical conditions. But that does not mean to say that hesitation should be imposed on others. And so that's one of the problems we have. The other problem also is that for a lot of people, especially the older generation, and this isn't just the BAME communities, but you will find that the older generation, without sounding ageist, it can be very difficult for them to access information, which is relatively online information. And that in itself. So one of the things that I had asked when we started doing things at Exeter Mosque was to actually have things like posters, visual information that people did not have to access online, if that makes sense. So it's information that's readily available where they don't have to be pushing buttons, they don't have to be tech savvy. And it would be nice to be able to have that information in various other public places where people can actually see the information. I think the other problem that the other problem is something that I've touched on already, is that actually, rather than people, sometimes it's really difficult for people to understand what is the right information. There is a right and wrong. So for somebody to post information on Facebook without a proper source of where they get that information from is quite dangerous. And that is the kind of information that actually makes people doubt why they should be taking up the vaccination. And I think that's our number one problem at the moment. Misinformation on platforms like Instagram, Twitter, Facebook particularly. So that's one of the bigger problems that I face in the Muslim community, because people tend to believe everything that they read in front of them. So on the one hand, you've got people that can't access information online, and on the other hand, you've got the people that can access it, but they're not necessarily going out of their way to verify whether this is the right information. Does it come from a gov.uk website? Does it come from the NHS? Or is it something that's just been copied and pasted from another source that isn't perhaps, I wouldn't say legitimate, but isn't perhaps the best place to get information from? So those are the two main sticking points that I've got at the moment. That's something that we need to work on.
Okay, thank you very much.
Thanks, Naomi. I think that's going to be particularly helpful when we look at the findings and the proposals, as Andrew, you mentioned later on, to understand what are those influences within our communities that we need to be aware of. I think will be really helpful. Because it's not just about the vaccine, it's going to be about how we continue that engagement, as you said, Andrew, and how we build on this. Simon.
Yeah, thanks, Naomi. In the past, I did a bit of work around supporting carers, and what we learned through the Hikmat Centre particularly was that we weren't maybe going to necessarily engage with some carers in the right way through traditional places like general practices and primary care, and that they would rather go to other places to have their medical information. Is that still the case? And if so, should we be communicating with the BAME community in all sorts of different places to where we're currently communicating?
I think it may not be a significant part of the population. I think mostly people are happy to go to their GPs to talk about whether it's immunization, whether it's vaccination, whether it's boosters. However, I do feel that there may be instances where people, I think one thing that's shown up with the previous vaccination session that we had at the mosque is that people feel free to be able to ask more questions. I mean, I think it's just familiarity of surroundings and familiarity of faces. Because the mosque is a community hub, it means that they know the imam really well, they know the volunteers that were there really well, and it just makes it easier for them to ask questions. So that there is, I do believe that I think there should be exploration of other means of people accessing information and not just through the GP. I'll be perfectly honest, I do kind of feel like perhaps that, and this isn't just to do with the NHS, there is something about inclusion and diversity, and there needs to be a tremendous amount of work around inclusion. And I think that's one of the major reasons why people might be reluctant to go to their GPs or to existing facilities, I guess, to be able to access information or access even medication. So I think that's a very broad and wide kind of thing that I've given you, because inclusion is not something that you're going to be able to, it's not a click of a button kind of thing. It's something that needs a tremendous amount of work, a tremendous amount of dialogue. It means building a relationship with the heritage community. So it's something that really needs to be explored. But you're absolutely right, Simon, that I feel there is perhaps not a significant number of people in the population, but I think there is some work that needs to be done towards inclusion, and you should definitely explore other ways of not just getting in touch with our communities, but actually maintaining some kind of a relationship. To kind of build bridges, if you like. I mean, it sounds a bit cliche, but actually building bridges is what the target should be. But the methodology is what we really need to be looking at.
Yeah.
Great, thank you. Thanks, Simon. One more comment from Gaynor, and then we'll let you get on your way, Naomi. Thank you, Gaynor.
That's fine.
Yeah, thank you, Naomi. No, I just wanted to say thank you, and the fact that you use the word heritage ethnicity instead of BAME, I think is really important to raise. And I think we are missing a trick here with like accessing communities that trust their own leaders. So, you know, your imam is able to reassure the people within his community or her community that, you know, that this is safe. And it's not just about the COVID vaccine, but it's about accessing medical care. And yeah, I think there is a real stigmatism sometimes with the NHS. So yeah, I think that's a really valid point. Thank you.
And a good point.
Can I just to give you so I work predominantly with Exeter Mosque. I work in what you would term as PR, public relations. And I was brought up in Scotland where there weren't many heritage communities there. So I'm very comfortable with working. Basically, I'm going to be blunt about this. I'm very comfortable working with the white community. But what I've got in front of me in the screen, I can see 9 people. All of these 9 individuals are, forgive me, but you're all 40 plus, you're white. And when I'm working with my community, it would be reassuring to see somebody of colour, perhaps somebody. It needs to be a mix of people from not just experienced people who have been through the rigmarole of life, but it would also be nice to see younger people who have certain legitimate concerns, something that isn't reflected here. I'm sorry to say, but I don't see people of colour. I don't see somebody who is particularly young, because within our BAME communities, within our ethnic heritage communities, the influencers are actually the younger people. It's not the older people. So when you do your convincing that this vaccination is good, this is good for your families and for the vulnerable people around you, this message needs to come from people of all demographics. I'm talking about age, I'm talking about colour, I'm talking about work experience. That's not reflective of the screen that I've got in front of me today. And the screen that I've got in front of me today is very typical, not just of the NHS, but I work closely. So when I was contacted to do the mass vaccination, it was through my work role with Inclusive Exeter. So I'm one of the directors of Inclusive Exeter, which is what you would perhaps loosely term as a BAME-led community interest company. And we do various projects with the interests of the BAME community in mind. But one of the problems we face with inclusion is that when we go to work with other organisations, it is very much the same demographics that I've got in front of me in my screen today. And that's something that needs to change. And I as a person of colour, I can only ask you to consider how you go about changing that. I can't really influence you in any other way. That's something that needs to be done from within your own organisation, if that makes sense. So I do keep saying that I don't mean to be ageist, but the reality for my community is that the influencers tend to be the younger people. So if they go back to their families and say, well, you know, Mom, there are certain risks and I'm feeling that I'm not going to take up the vaccination. You can if you want to, but I'm not going to take it up. Actually, that's a really powerful message. That's not very helpful for me as an individual who would like to see everyone vaccinated. Does that make sense?
That's really helpful, Naomi. And I think that will help feed into our discussions that we have later, because it's not only what we would like to do, but what your challenge is, how we do it, and how we involve, as you say, the widest spectrum of people to be part of that engagement process and involvement process. Thank you, Naomi. I wish you well, whichever part of the country you're going to. But thank you for what you've started in Exeter, and I think we're charged from our end of making sure that we build on that. So thank you for your time this morning. and I wish you all the best. Thank you.
Thank you so much. Yeah, I mean, just by way of just saying, I hope to, Exeter Mosque has requested that I continue working. I think they've just logged on to the fact that because of the pandemic, we now realise we can actually do a tremendous amount of work remotely. So I will still remain in contact, and I will still remain the contact for this particular purpose, for the purposes of following up vaccinations. So even if I'm going to be in another part of the UK, I am still involved. But I realistically, once I'm in London, once 6 months has gone down the line, there may be a change, and I may at that point kind of hand over to someone else and say, this is the person that you will need to be in touch with. Or it might be that I can continue things as they go.
Well, we'll continue working with you for as long as you're involved in Exeter. Then. Thank you very much, Naomi.
Brilliant.
Thanks for joining us this morning.
Thank you. Brilliant. Thanks, Darren, as well. Thanks, everyone. Bye.
Bye. Bye. Thanks very much, Naomi.
Okay, so welcome and apologies. So welcome everyone who's joining us. I have got a number of apologies. Sorry, let me just get the right bit of paper on the screen. So apologies from Susie Leather, from Steve Brown, from Ruth Harrell, but Sarah Lees is here, deputising, and apologies from Charlotte Burrows. But we've also got Anne James from UHP is with us, and I'm just scanning down to see if any of the other team from the western part of our team are here. I can't see. I think it's just Anne. So and Joe. Sorry, Joe Beer is also with us. So welcome both of you. We don't have any questions from members of the public. We've got the register of interests. Can I ask people if they've got anything that they want to add or need to alter within the register? Please can let me know. And any interests that are particularly relevant to any of the items that we're going to be covering. Gaynor.
Thank you. If you could just alter that I don't work for Northern Devon Health Trust anymore.
Right. Okay. All right. If you can let Nikki know the details of that, then we can make sure that gets updated. Thank you very much. Okay, and then we are on to the minutes of the last meeting. So this is from the 29th of April. So this is for accuracy. And if I take it by the page numbers of the minutes themselves, so anything you want to raise with pages 1 or 2, 3 or 4, 5 and 6, 7, 8, 9 and 10. So we will take those as an accurate representation of our last public governing body meeting, which takes us to the action log. In the action log, we have got 7 actions there. The first one is in progress, which is a briefing paper on MIUs and the current position of out-of-hospital care. That's been added to the forward planner. So now that's on the forward planner. Can we could, I'm quite comfortable unless people that think otherwise to close that as an action, because if it's on the planner then we make sure that we follow that up. And we'll close that. The second action was with Andrew and Darren to link together to discuss how we better recognise the role of volunteers play in services that we delivered. Andrew, I don't think Darren's not still on our call. Andrew, that's in progress, is that?
It is, just Chair, down 2 avenues really. One is Darren liaises quite regularly with about 30 BCSE organisations as part of a working group. So he's going to take their view on what we could do to promote what volunteers do and what they bring to the NHS. And also Darren and I have met with Jenny Warren just to discuss how we promote the work of volunteers, so the good work that they're doing to support NHS services. So it's been taken down through both those channels.
Okay, and something coming back to us so that we can close the loop on that?
Can do, happy to.
Timescale?
Perhaps at the next meeting.
Yeah, next meeting. Okay, so Nikki, if you can add that to the next meeting's agenda, that'd be great, and then we can close it off at that stage. Item 4 is for closure because the briefing was supplied. Item 5 is when we look at our activity plans, is comparing where we are now compared to pre-COVID. Sheila, if you can just pick that up. I know you've only just started, so we'll leave that one as in progress, and that probably needs a little bit of a discussion with you. I'm quite happy to have that to see if we can make sure that we can get that covered off.
Of course.
And then Andrew, a couple of minor amendments to the corporate objectives. That's work in progress, but that will come back at the next quarterly review of the objectives. Have those amendments been made? They've been made, and of course, what we'll see at the next review, which will be in July, is obviously progress on all of the objectives. So we've made sure that all your comments have been taken on board. They were really helpful. Fine. So if they've been made and we've got a regular report coming back to governing body each quarter, then my suggestion is that we close that action. Okay. And then the last one is a long COVID evaluation report. Joe, that's now on the forward planner for October, because then we will have had 6 months of the pathway and we'll have a decent length to review that. Is that right?
Yes, that's right, Paul.
Okay. So again, and now it's on the forward planner. I think that's a reasonable thing to then close that as an action. Okay. So that then brings us to the next item. Then it's the schedule, and it's just really highlighting for governing body. So it's a page at a glance, you know, on a page, the things that we are going to be focusing on today. So I think the main things are the two approval points. One is around the ICP proposal, which we'll come to shortly, and then there are some recommendations that come through in the BAME review that Nous did for us. So those are the two approval things to highlight on, and we'll also be joined, I think Anna's joining us later, because we've got to focus on the Plymouth LCP, which I think is timely given the other things that we're going to be discussing this afternoon. Okay. The Chair's report, I will take that as read. I think just really to highlight the opportunity that we have and the support that we have both from NHS England and from within the system to really make sure that during the transition period that we've got between now and next April, the understanding of the importance of clinical leadership that CCGs have managed to develop and build on, that we don't lose that. And there's plenty of opportunities that I'm involved in and others are involved in to make sure that we not only maintain that level of clinical leadership, but we improve and increase and diversify that. So that feels really positive, and those are probably the only things that I would bring out of that report. Any questions or comments? No? Then Jane, over to you for the Accountable Officer's report, please.
Okay, thank you. So similarly, I will probably just take it as read. Just to say, I think a number of the items are actually on the agenda going forward, and obviously we've just picked up Naomi's excellent discussion and presentation about vaccination report with this brief update on the funding for the accelerator programme, and I think it's fair to say we'll be continuing to brief the board on that. And then the other thing I just wanted to raise was some of the work that's happening just in terms of reaching out to our communities under section 6, which is sort of, I suppose, understanding essentially people's current use of services, given the pressures that I think everyone is experiencing, and just trying to use that intelligence and insight into how then we might need to adapt some of our services. And then, as I think you mentioned, Paul, obviously the ICS development process continues. We are still waiting, I suppose, the paper that will give a bit more information about the operating model for the ICS. That was due a couple of weeks ago, and we are promised it, I think, next week. So once we have that, we will also be factoring that in across all of our leads across the system. And just one final thing, just in terms, obviously, with the appointment of a new chief exec for the NHS, that will obviously have a significant, it will be a significant period of our time, and we will be obviously keen to work with them and their team as soon as possible to ensure we get Devon on the map. So I've been working with Andrew on that, but we obviously will depend a little bit on who it is. So there we go.
Thank you. Nick.
Thank you, Chair. Jane, are we confident that we've got enough orthopods to staff the increased activity at the Nightingale? And where are they coming from?
So I think we've got John Finn on the call, because he is living and breathing this at the moment. And just to say that Suzanne Tracy is the lead chief exec on this, and obviously workforce is a really important plank. But I don't know, John, do you want to pick up what we know at the moment about that?
Yeah. So in terms of the workforce, actually, in terms of orthopods to staff it, I think that's not a challenge. The staffing in terms of the theatre staff is a greater challenge, and that's part of the programme to recruit to the Nightingale rather than relying on the majority of staff to come from other trusts.
Okay, so where are the orthopods coming from, John, if that's not a problem?
Yeah, so we had a session with the Devon orthopods during the week. I said you would expect in terms of travel, the majority of the orthopods to come from the eastern and northern system and from Torbay, but there is still a dialogue in terms of Plymouth if orthopods would be willing to travel. But in terms of orthopedic surgeons, that hasn't been identified as a risk. Actually, staff is, of course, but not in terms of orthopedic surgeons.
Right. Okay, thanks.
Thank you. Thank you, Nick. Graham.
Thank you, Chair. Jane, it's really encouraging to read in section 5 of your report about the equality and diversity issues and the survey on sexual orientation and gender identity. And of course, we've got the NOUS report later. Without wishing to either overload you or us, I'm very keen that we also look at disability issues, and in particularly staff who may have hidden disability issues. So if we could pick that up at some point, that would be really helpful.
No, that's already on the to-do list, and I suppose having established a number of networks in my previous job in terms of a women's network as well as disability or ability, which also includes, as you say, those hidden areas, and dyslexia is a good example. So that's work under progress, and part of my conversations with the Staff Partnership Board, which I joined, I think it was this month, wasn't it, Andrew? Was exactly that. So it is part of our inclusion approach across, well, not just within the CCG, but it will be an important plank across the ICS.
Great, thank you, Jane. John W.
Thank you, Jane. Section 6, just you mentioned there Virtual Voices Citizens Panel. Bearing in mind the conversation we just had, can you assure me that we have the appropriate blend of ethnic heritage groups as part of that panel?
Andrew might want to jump in there.
Yes, John, we do. The panel of the 1,700, just over 1,700 people is truly representative of the population. But what we're going to do, John, recognising that we want to do more work in this area, we're thinking of having a sort of almost like a subgroup as part of Virtual Voices, so that we can test things and engage with the sort of the communities like Naomi's on a more regular basis. So I think that's part and parcel of how we strengthen the panel.
And just to follow up on that, then, if I may, Chair, any plans to make that sort of Virtual Voices capacity available to LCPs at an LCP level, because that would be a very useful way for us to engage?
It's totally available, John. You could use it. You could use it tomorrow if you wish. And in fact, I've been engaging with, and I meet with your sort of local communications and involvement leads on a weekly basis. And one of the plans is, rather than everyone inventing their own, it makes sense we use that panel. So I've said they can use it as and when they wish, because it's a great thing for us to have.
Okay, lovely. Thanks.
Great, thank you. And there's one more hand. Sorry, John, was that a legacy hand from pre-4, or is there something you wanted to add?
My hand should be down.
No, sorry, John Finn. No, that's the legacy. Okay. Thank you very much, Jane. And so let's move on to item 8.1, which is the ICP. We're going to go through this because we've got guests with us. I'm aware that people went straight from one meeting to another, and we will then have a break after this particular item. I think that will be helpful and healthy for all concerned. Joe, I think you're starting off, and Sonia should be joining us shortly. And I just guess I'm drawn by the three things that you're asking governing body to reflect on, and part of this item and this decision making. And it'd be really helpful for you to give us a steer, really focusing on those three items that you've articulated within the paper. Thank you.
Lovely. Thank you very much, Chair. And everyone will have seen the paper, so I'm going to keep the presentation very brief. I think the first thing I want to do is just thank, we've also got some other guests here today as well who've joined us. So I want to thank, first of all, Anne James, Joe Beer and Michelle Thomas for joining us today, but I think also more significantly for the leadership that's been shown over the last couple of years in developing this proposal as we move forward. And I think not only the significant hard work that has gone into that, but the way that's been done as well. Also want opportunity as well. So I don't think Anna and Sonia will both join us in a moment, but we're a little bit ahead of time, but also want to thank the team. And that's really been a significant team effort as well across the CCG in getting us to this point. The first thing, so I really wanted to, I think, remind us of is where this came from, where this started. So as commissioners, we've quite a long time ago, we set out our strategic direction for vertical integration, and the approach we are proposing today will really enable us to embed in the Western system the collaborative working that's been going on between partners over the last few years, but particularly we've seen develop, I think, over the pandemic in the last 12 months. And this approach will also bring us, importantly, I think as well, a consistent approach across our 4 localities as well. The other thing I wanted to point out as well is that we will also be commissioning in quite a different way than we've done before. So I think this is quite a new, brave approach. And we will be moving away really from what feels like quite a traditional commissioning contracting approach with our providers to a much more collaborative one that's really focused on outcomes. And we'll really build on that collaboration through the LCPs, where we'll all collectively be held account for making sure that the ICP is a success as we move forward. So I'm just going to pop up a couple of slides. So if you just bear with me for 2 seconds. There we go. If you could just let me know, Paul, if you can see the slides.
Yeah, we can. Thank you very much, Joe.
Lovely. Thank you very much. Okay, so there's a couple of things that we want to touch on today. So the first thing will be the benefits that we'll see for the population from the integrated care provider partnership, and some of the changes we will see early on, how we will manage, I think importantly, delivery of those changes collectively, and then lastly I will focus on the key recommendations. So what difference will the ICP make? I'm not going to, as I said, I'm going to keep this as brief as possible, and all of this information is included within the report. And Sonia will take us through in a moment some of the tangible difference we will see. But really, in essence, this is about a model of care that focuses on the individual. This is about supporting the individual to give them greater control, greater level of independence to stay in their own home for as long as possible, and only to go to hospital when it's absolutely necessary. And when individuals do need to go to hospital, that we support them to get back in their own homes and regain their confidence and independence as quickly as we can. So this will be significant benefit to individuals. We expect to see an improvement in terms of people's experience of how they experience health and social care, but also the outcomes as well for those individuals. We also know, though, that looking at our benchmarking, this should have a significant benefit for the whole system and our key partners when we look at things like admission rates and lengths of stay across our localities within Devon. So I'm going to hand over now to Sonia, who I hope has joined us, just to take us through a couple slides on some of the specifics that we will see for patients.
Thank you. So in terms of what difference this will make and how people in our local population will access care differently, you'll see here a picture of the model as described by our partners, and it's also in the paper. So really this is about focusing very early on and preventing health deterioration, so making sure that people are kept well in their community, as close to home as possible. Where they do need access to planned and routine care, that they can do so in a timely fashion, again as close to possible in terms of how they naturally live their lives. And if they do need access to urgent care or go into crisis, that is also done in such a way that is wrapped around all the community-based offer and the way that people normally access services and live their lives, and set on really solid foundations, which you'll see here in this picture, which include, of course, the foundations in terms of social care, mental health, health improvement, physical health, and others, but very importantly, on a different way of working. If I go to the next slide, so this model of integration is important to describe, but what will that mean to people in terms of that first year? What's going to look and feel different? And certainly we can expect to see some tangible differences in the areas. Again, it's in the paperwork, but I wanted to highlight some specific examples in which this is going to look and feel different. So for example, when people need care or they need help or support in any which way or form, we will see a single point of access. So a service hub that will act as that single front door, where it doesn't matter where people present in the system or how people are accessing service, that they get that that support up front, and we're expecting to see that in year one. The second bit as well we're expecting to see is particularly enhancing the skills and expertise and people that are based in the way that people access care through their GPs and primary care already at the moment. So we'll be enhancing, for example, how those local teams work with care providers, so care homes, the enhanced care service, but also additional mental health roles, additional services and support for people with mental health through the community mental health framework development. In essence, to make sure that more people are able to be supported closer to home and prevent the need for an urgent response, because people are getting support early on in their needs and in a different way. And then finally, as a third example, but there's many more here, I know there's more in the papers, based on some of our evidence and our population health management data, really creating ways in which people with particular conditions, and there's examples given here, can be better supported, which will see a reduction in the need to be referred to some of our more secondary care services, but also which we'll see that actually when people do need that specialist support, that they need that for less time and in less intensive circumstances. And this will create a different relationship, a very relational rather than a referral based one, which will be for the benefit of our population. So there's some tangible things here, in particularly in respiratory, cardiology and stroke and others, where we're going to start to see differences in the first year. So the point, though, in all of this, though, is that the transformation and delivery of our integrated care partnership plans really does sit within a context of an integrated way of working across the wider Devon system, and in particular within our local care partnerships locally. And we need to be very mindful of that context in ensuring that we all work together to transform and deliver this new way of working. There is an integrated system performance improvement framework which has been developed, which will support us in collectively improving our services and our offer for our population. And of course, we need to manage the contractual nature of this as well within that context. So I think the bit I wanted to highlight here was we've really given a lot of consideration and discussion about how much this relies on the relationships that we have across the system, both within the ICP partnership, but within the wider system and the context in which we work. And so we have given a lot of thought to those relationships and how we foster and develop them. There's a lot of learning from COVID, which is referenced as well, about what truly can be achieved when you have that single common purpose and you all work together. And the evidence, particularly in the last year, but even before that, where that is a uniting purpose, true transformation and true change can really be delivered well and delivered quickly for the local population. In that context then, though, for this year, this particular year, given the multiple challenges that we all are presented with, we are putting some bespoke arrangements in place, and in the paper it's referenced as well around an executive arrangement where we can make sure we do share intelligence early, work together, mitigate any risks that may arise, and support both the ICP, so the partnership, but all of us in delivering this. Next slide. Joe.
Okay. Thank you, Sonia. So that brings us to the recommendations. So as you outlined, I think at the beginning, Paul, subject to approval by Plymouth City Council's executive as the Associate Commissioner, and who have obviously statutory responsibility for social care. The recommendation made by the ICP Executive Group is that the CCG Governing Body today approve the award of the contract for the delivery of the ICP services to University Hospitals Plymouth as the lead provider, and that the contract commences on the 1st of July for a period of 10 years with a possible extension for a further 5 years. So I'm going to stop sharing my screen, hopefully at this point, and would be really happy to take comments and questions.
Thank you very much, Joe and Sonia. So I guess the purpose of our questions and discussion now is to make sure that we feel that we've got the information and assurance levels we need to make that decision that has been asked of us by Joe. And again, let's go back to the focus. Have we appropriately considered the risks and we are satisfied with the mitigations that are in place? Are we clear about what those transformational benefits and delivery plans are? And are we do we agree with the contractual terms and the governance arrangements that are placed around this? So those are the 3 focuses to try and enable us to get to that decision. So any questions or comments for Joe or Sonia? Judy.
Thank you very much, Joe, and thank you again to all the colleagues in the system who've developed this proposal. I have 2 questions, 1 comment. I really liked the point you made, Sonia, about the importance of the executive group and the senior focus on issues in the early period, and would encourage everyone to really make sure that works to help with any issues that come up in this very ambitious and exciting plan. I have 1 area of confusion and 1 area wanting assurance. Joe, I'm going to ask if you could just assure us, I think you've had advice from NHS England, advice from lawyers. Could you just assure us that the advice from those people has been taken into account in the final proposal? And the other thing I remain a tiny bit confused about, and it matters to me because I'm concerned about prevention. If you look on page 3 of the report, of the paper, page 5, sorry, it's very clear that the outlined scope here is for people with complex needs, mental health services, learning disability and autism, adult social care, the priority groups. Brilliant, that's great. Later on, we did ask way back, and it's listed at the bottom of page 8, a comprehensive offer for prevention and self-care for the whole population. And I'm just a tinsy bit confused about whether we are talking about running the prevention services for the whole population, as well as running the integrated care services, including prevention, for those particular groups of people. And I would just welcome clarity so that later down the line, when I ask questions about prevention, I know what we're expecting of the ICP. Thank you.
Let's take Judy's comments and questions before we move to anyone else, because there's quite a lot in there for you, Joe, isn't there?
Yeah, okay. Thank you very much, Chair. And thank you, Judy, for your comments and questions. Yes, completely agree with the statement you made at the beginning, Judy, about the importance of that executive group up front. And I think really all working collectively together at that level earlier on to make sure we're tackling some of the challenges that undoubtedly we know we will have, and I feel confident that we have that set up, and we have actually what's a really good, well-functioning LCP as well in Plymouth, and we know we're developing the same in the Western locality as well. So that gives me confidence around how partners will be working together to achieve that. There is just moving on to your question, Judy, about assurance around the legal advice and advice from NHS England. So you will see particularly the focus from NHS England was around some of those high level strategic risks, which are the areas we've sought to highlight specifically in this report now for the public governing body, and that hopefully within that risk register we've been able to adequately cover off in terms of mitigation that we've agreed with between us and our partners in working on this, and feel confident that we've got to a place that we feel confident we've done as much as we can to mitigate those risks, and that we will also have a process and governance set up to continue to monitor those risks and work on those risks to mitigate them moving forward as well. In terms of the advice from the lawyers, there was some technical advice, particularly focused, as you'd expect, around the contract. So particularly in there was a change that we made to the contract terms, but also some advice in terms of partnership arrangement around how we work with Plymouth City Council as sort of co-commissioners in this arrangement as well. And hopefully you'll be able to see within the appendix how we've sort of mitigated against those risks. But again, feel confident that we've worked through those collectively and feel in a good place in terms of moving forward on those risks. In terms of prevention, I'll probably just bring Anna in as well in a moment, so I think it will be helpful to give Anna an opportunity to just talking just a little bit in brief detail about how it will work. But we were really focused at the start of this on this being about the whole person and the whole pathway. And I know, talking to colleagues and having seen the business case that sits behind this proposal, there is a real focus on upstream self-care prevention. What we haven't done is we haven't moved the delivery of all prevention services into this contract, but it's about how those partners work together and relate to each other as well. And I don't know, Anna, do you just want to say a few words about that?
Yeah, thanks, Jo. So I think you're absolutely right in terms of that description. So Judy, I suppose when we look at some of the wellbeing provision and some of that rich tapestry of the community and voluntary sector, often small providers and those types of things, some of which aren't necessarily via commissioned contracts. So actually what the specification describes is the very collaborative and joint work that UHP and Livewell will embed with that wider community to help and support deliver the wellbeing and prevention agenda. So within the scope of this contract is the health improvement functions, which currently sit within Livewell. So that is absolutely within scope. But some of those sort of smaller wellbeing services will be grouping around the partnership. And I think, the model clearly describes that desire to upstream support and to make sure that we get that real community resilience and community empowerment agenda at the heart of this as we move through the length of this contract. I hope that helps.
Thank you. Thank you.
So when we cover some of these things, I am going to check back with those who've raised their questions just to check that you're comfortable with you've had enough of an answer. Just we don't want to leave things hanging when we come to a decision making. So Judy, are you happy?
Thank you very much. I'm assured by what I've been told. Thank you.
Okay, thank you. David Greenwell, and then we'll take Nick Kennedy. So we'll do a double act with you two, please.
Thanks very much. I just wanted to stick with the clinical rather than the contractual, and I really just wanted to say, in terms of the clinical, we've seen earlier this morning quite a lot of information about the new model of care, but I just really wanted to reassure non-clinicians that although it is a very coherent model that they've presented, actually it's not new and it's not untried. So the integration journey that the health and social care services have been taking is actually, it's been going on a long time, and the model of care that's presented within this document is neither new nor untried. So I just really wanted to reassure the non-clinicians that this is not something that's been plucked out of the air and we hope it'll work. It's actually a model that's working elsewhere, and so this is not new. It's pulling lots of existing work together and taking the best of what's out there. So I just wanted to make that comment. Thanks.
David, thank you. That's really helpful. Nick.
Thank you. So my question just goes back to the risks, really. You've talked really articulately and given me actually quite a bit of reassurance, even this morning, on how you've approached the risks and how you plan to mitigate them in the future. Because there have been contracts in the past for which unforeseen risks have become clear not long after the contracts have been awarded. And I just so what I really want to just be clear about is that you all feel that you have all had the opportunity to really articulate and understand the risks, and that there isn't a sort of groupthink thing here that that risks are being overlooked or anything like that, and that actually the assurances you're giving us really are based on a really comprehensive review of all possible risks that you can think of.
Yeah, shall I start to answer that one, Chair? Thank you. Yeah, thank you, Nick, for that question. I think it's really important, and some of us have been working on this collectively for a very long time. So I think you ask a really good question. I think there've been a lot of people, as you know, that have been involved in this all the way through from all sides, Nick. We've had an exec sort of executive ICP group, which has involved non-executives and clinicians from this governing body, and you will have seen particularly probably over the last 6 months or so, very recent briefings to governing body, and I think we've given a good opportunity, hopefully, I think along the way, to be asked those questions specifically around some of the more strategic risks, but also some of the operational ones as well. I think also the process that we went through within NHS England and NHSI was really important in that as well. So I think what they really focused on, although yes, they went through the detail in terms of the business case, the outcomes framework, etc., in the contract, actually they really focused on those strategic risks, things about relationships, how we'll work together, what this will look like after we've signed the contract. That was very much the focus for them, and actually that really brought to the fore some of those more strategic risks that you'll see in the report, actually. And I do think that gave a really good opportunity for some external scrutiny in this as well.
Is that okay, Nick?
I think so. I guess just to go, are you able to reassure us that all of you are involved in this and really have had the opportunity to really articulate out any concerns you may have about risks, that there isn't anything hidden, really, I guess is the issue, or unarticulated? Yeah,
so I'll probably let so Nick's put his hand up, and Nick's obviously our non-executive on the ICP executive group, so I think it would be helpful to hear from Nick at this point.
Thank you.
So the simple answer, Nick, is yes. You probably want a bit more detail than that, though. So a couple of examples where I think I've banged the drum quite heavily over the last 18 months is one about the overall and detail of the legal risks. And I've been quite insistent that we make sure we take more legal advice from actual lawyers rather than simply relying on the CSU, despite the CSU being very high quality and giving us some really good advice, actually, but they're not lawyers. And so there's a lot of stuff that I felt we should double check with lawyers, and that's all been done. And then I've been quite vocal about concerns I've had along the way about timescales. And quite often I've been saying, I don't see why we're trying to get this bit done by this sort of imaginary deadline. And on some occasions I've been persuaded, on others we've shifted those deadlines. So I feel that I've had absolutely a good opportunity to raise anything that I felt was not working properly. And I've always had good responses from Jo and her team. And just to save me putting my hand up again, Paul, could I just record my absolute thanks to Jo, Sonia and Anna, who have worked really, really hard on getting this, particularly Sonia and Anna, who've been working on this for the best part of 2 years. It's been quite a grievous process, and they've stuck with it really, really well. And I think this is the final outcome is a really good result for the people of Plymouth and the rest of Devon. So thank you, guys.
Great, thank you very much, Nick.
Thank you.
Can I just, before we, because Simon's got his hand up as well, Joe, just on that risk bit. So on overall page 66, you've got the ICP Risk Log, and you've got the post-mitigation RAG rating and risk numbers, and the target by which we would get to that is 4 days from now. So are we on track to having satisfactorily mitigated those risks, particularly those at 16, from 16 to 12? Is that where that new risk is likely to sit in 4 days' time?
Yes, and some of that, Paul, is about getting to this point with governing body as well. So recognising so at the last ICP we reviewed those risks, and we did agree that we would de-escalate some of those risks. That's our current position, but some of that is still about getting to the point of sign off and go live, and at that point those risks transfer then onto a local risk register, if you like, for the Western LCP. So we'll make sure that they aren't lost.
Okay, thanks very much, Joe. Simon.
Yeah, thank you. I'd just like to give my thanks to everyone that's worked so hard on this, but I'd like to say that middle risk about contingency in the event of provider landscape changes. As a governing body member, I've heard quite a lot over the years about the sustainability of general practice in the western part of our system. And today, on a day when national news is primary care could be being overwhelmed by the demand of patients post-COVID that's never been seen before, I certainly experienced this demand as I must see my GP. I don't want to see one of your salary doctor. I must see my partner GP. I don't want to see a salary GP. I don't want to see a nurse practitioner, or I must see my consultant. Do you think that the model actually is taking sufficient notice of that part of the landscape, which may inevitably change over the next few months or years in the Western locality?
Yeah. Thank you very much, Simon. I'll take. I think you're the only one left your hand up, so I'll take that question. I think again, really good and pertinent question to the where we are, the here and now. I think I'm not going to sit here and say this is going to solve all of primary care's problems in Plymouth, because there are we have a strategy and a work programme to help support that as well. But this will have, I'm confident, will have a big impact. I think this is absolutely focused on supporting those patients at highest risk, an individual approach to those patients. And I think by really embedding population health management, and I think you heard this morning, I think the passion with which the Western locality, in particular providers, want to move forward with population health management, that can only help support general practice. We hear a lot about the work that we want to do to support people to stay at home and the impact that will have on the acute system, but that also has an impact on primary care as well, and we can't forget that. I think the other thing as well I'd just like to say is as well, it's back to that partnership way of working, and what we've seen through partners working together in this way and the continual development of the LCP is the opportunities for those relationships to really come together and for partners to support each other. And just this week we've got a practice that's struggling a little bit at the moment in Plymouth, and automatically I've seen both UHP and Livewell come to the table straight away to offer help, support and resources in that space as well. So I think it's about how you work together as a collective that this will really kind of bring that to the fore.
Thanks, Joe. Thanks, Simon. Did you want to come back?
I just wanted to say, I think it's great to hear all that, Joe, and I agree with you. By working together, hopefully we can create that capacity. I think there is also a message to go out there to the public to say, actually, the GPs aren't the only place where you can get help. There is a collaborative group of primary care professionals who can help you, and actually going to your GP isn't the only answer, because I think at the moment there is a little bit of a sort of two-door approach from the patient's perspective, and we need to create a much broader, a more open door where they know they can get the response that they need, because sometimes it just comes in through one portal.
Yeah, and I think that's what we'll see with this, Simon, is much more of a focus on that self-care, that social prescribing. I think we'll be able to deliver that through this model. Will be part of that, delivering that option to patients.
And that does refer back, Simon, I think, to Jane's AO report, her sort of item 6 around patient decision making, and the local communications approach, which is there to tackle some of those things and provide some of those options and highlight them to some of our patients. So that should hopefully come from that Jane brought to us earlier. Sheila.
Thank you, Paul. So it was just really a bit of clarity and hopefully to provide some assurance on the QEIA component, because I think, you know, that at the heart of this contract for me is addressing our inequalities in the system. And we struggled a bit with the first QEIA because it was so high level, and it was then reviewed, and we approved the final review, but we also made a recommendation, as you can see there, that the specific work streams would be individually QEIA'd, and actually we did ask for that to be done. It sounds like it's going to be done in a more leisurely way than I think we actually requested and recommended, and I think that should be seen as a really positive thing. So all of those work streams will have an individual QEIA, which will provide even more assurance about how this work stream, all of these work streams, are going to address our inequalities. And I think that's so important that I wanted to emphasise that. I sit on the QEIA panel and I sit on the ICP executive, as well as being a GP in the Western system. So I just felt that I really wanted to make that clear to everybody.
Thanks, Julia, that's really helpful. So we've got no more questions or comments, and I think the general feeling is actually there's been a lot of hard work gone into this. There's been a lot of hard work, not just by one party, but actually across the system in the West and from a large number of the team within the CCG, with some really good assurance processes along the way, with Nick Ball being part of that. And I think there is still a recognition that not all risks have disappeared in this, that there are still some that we need to be cognizant of and aware of, and make sure that they don't get lost or not, you know, or covered over or anything like that. That actually we have, you know, that ongoing relationship, that ongoing transparency to get the most out of this opportunity. So I guess that takes us to a point with all of that in, you know, bearing all of that in mind and going back to those three things for us to reflect on around the risks, and are we satisfied with the mitigations? That are we convinced that the transformational benefits and delivery plans are there? And do we believe that we've got the contractual terms and governance arrangements right? And then the sum of that is, do we therefore feel subject to PCC's executive? Do we feel the decision for the CCG is to award the contract for the ICP to the Western locality, to UHP as the lead provider? Now, most people present are voting members, so our colleagues from local authorities, you are definitely a valued member of the committee, but not voting, unfortunately, and to both our associate non-executives, again, equally valued, but from our constitution, not voting. But all other members, can I ask you, please, if you are in favour of this award to UHP, to raise your virtual hand, please. Okay, so I'm just going to scan down, and we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18 hands raised. Nikki, if we can document that, and if everyone can now lower their hands. And I'm pretty sure that was unanimous, but just to be clear, can I ask if there is anyone who voting against? Please raise your hand. And then anyone who abstains, please raise your hand. So that's 0 on both of those, Nikki. So Joe, Anna, and I know Anne and Joe Beer are also here with us, and Sonia. I think that's a resounding vote of confidence in the work that you've done and the plans that you've got, and the possibilities that open up for Plymouth through this ICP. So thank you for your hard work. Thank you for your vision and your passion, and we are excited to see what comes of it. Thank you. Governing body, we could press on, but I'm aware that that actually it is healthy for people to have some breathing space. So people have got a chance to stretch their legs properly. Let's do, well, it's 12:25. Let's restart again. So that's 9 minutes by my watch. Great. I do like promptness, at least at the start of meetings, even if I don't achieve it at the end. Welcome back, everyone. So let's press on with our agenda, just so that we are clear as to what we still have in hand. We will come to the item 8.2 very shortly. We'll take the LCP reports as read and then allow time for the deep dive in Plymouth at 9.1. And all the items in 10, there are no actions specific for governing bodies, so we will take those as read as well. So the two main areas of focus are the report we're going to come to now with Andrew, and then the deep dive in Plymouth. Those are the two key bits of business left to do for governing body. So Andrew, over to you.
Yeah, thank you, Chair. And I may have input also from Lincoln and from Nellie, who I think may have joined us as well. But if I start, because I think this is a really important topic, isn't it, that we talked a little bit about earlier this morning with Naomi. So you will be aware that we commissioned a report as a system undertaken by the Nous Group to look at the experiences of BAME staff and service users. And you'll be aware that there's much debate around the phrase BAME, and I quite liked Naomi's alternative in heritage ethnicity, or heritage ethnicities, which is a great phrase. However, many of our networks are still using the BAME phrase, and of course you'll see that also in the report. But I may, if that's okay, use some of Naomi's suggestions as we go through. The report, as I said, is a really important one, and I guess makes sobering reading, isn't it? If we look at it, it highlights, I think, in Devon that we've got an awful lot of work to do to enhance staff and service user experiences. And you'll see in the report as well, which is really detailed, that many people with heritage ethnicity have worse experiences of health and care. COVID has obviously brought a sharper focus on some of the inequalities that they face. And our staff too, as you'll see, are underrepresented at senior level and often experience discrimination or don't feel organisations take the equality agenda seriously. It also highlights, I guess, some gaps in information and data. It says that we often don't have the data and information we need to show how people fare and the experiences they have of healthcare, or indeed their experience in the working environment. So what we've done, and we heard from many people that were involved in the report, was that there's been lots of reports done in the past and not a lot has changed. So we're determined to change that. And therefore, what we've done is we've worked really closely with Lincoln and with his inequalities leadership group to pull together a framework for action. So you'll see in the pack, there's not only a copy of the report that Nous did for us, but also a suggested implementation framework, which captures all of the actions, the 27 key recommendations for action that Nous highlighted for us to consider. And the framework's important because what it does is it helps us identify perhaps who will take forward, both at system level and at LCP or partner organisation level, the recommendations that they've highlighted. So on the 12th of May, Lincoln's group looked through in detail at the implementation plan that we put together and approved it, felt it was a sensible way of us, in effect, allocating responsibilities for various actions so we don't lose any of the richness that's in the report. We've also begun to share a copy of the Nous report with those that were involved. Again, that was a criticism of the past. We often do reports, but don't really share what the findings are. So we wrote out during Equality and Diversity Week fairly recently, we wrote out to all those people that were involved and shared a copy of the report so they could see what the findings were and what the recommendations were. We also plan to publish the report in a bigger way as well once it's been through governing body, and we're going to accompany it with a short film, which I think brings to life some of the experiences that people have faced. And of course, the report will be available in all accessible formats. We did hear, Chair, I think, didn't we, very clearly that Naomi suggested that we need to do much more work to work with local influencers, with local community hubs, and build relationships with those from the communities that we're talking about. And so for me, I think it's really important that before perhaps we consider the three elements that we want GB to look at. So one is to consider the report in itself, approve the implementation plan, and consider perhaps how we take this work forward and resource it as a system, and indeed even think about whether we widen its focus so that it truly does focus on the equality, diversity and inclusion agenda. But before I do that, I wondered whether Lincoln or Nellie wanted to add anything, because they've been really crucial to some of this work.
Yeah, Andrew, I'm happy to add some comments. And I suppose for me, three broad comments to make. The first is to sit this in the wider context of inequalities and other groups that have less than optimal access, experience and outcomes with the NHS and indeed with wider public services. So there's a national push now in terms of people from Black and minority ethnic, other heritage ethnicities, and deprivation, index of multiple deprivation. But the principles here, I think, equally apply to people with learning disability, autism, severe mental illness, sexual orientation, gender identity. So it's important, while not diluting the emphasis on ethnicities, that we see the principles as applying. And my experience has been, when we do things well for marginalized groups, we tend to do it, we tend to improve access, experience, outcomes for everyone. So I think that we're not doing this as just another group or another focus peripherally, but if we do this well, if we implement these recommendations, the implications for all our people, all of our patients and populations, I'm sure we'll see improvement. Second comment I want to make, I'm reminded of a quote by a previous Director General of the World Health Organization, and Dr. Lee, and he said, to make people count, we first need to be able to count people. And I think that comes back to the data issues, that what we're finding, those areas across the country who have made most progress in terms of identifying and doing actions, particularly around recovering their waiting lists, etc., are the systems that have invested in their data systems, in counting people, in making sure that the data is captured at the front line, but more importantly, is reflected back to the front line, because that's where the action is. It's not just doing sophisticated analyses that are kept in one part of the organization. It's being able, each team being able to have access to their aggregate data and being able to interrogate what their services are doing in terms of some of those key groups, people of different heritage, ethnicities, as we've been talking to today. And finally, we talked about influencers, and I think our staff are the important ambassadors back to the community, etc., about the seriousness with which we take issues in the NHS. And if you think about vaccine hesitancy and so forth, Naomi highlighted some of this. There's so much information out there. My own experience working with and being part of a Black heritage ethnicity is that often people will say to me, there is so much information out there, this is educated people as well, that you don't know what to believe. And very often it is the trusted voice. Our staff who work in the NHS, if they're able to, with confidence, influence their families and communities, they are the catalyst for overcoming vaccine hesitancy. If they themselves feel a sense of distrust about the organizations for which they work, overcoming their own hesitancy is going to be a huge difficulty. So the importance of looking at our staff experience, the importance of looking at how staff progress through the NHS, and it's been, and this report picks it up, that at the front lines, we have a higher proportion of people from different heritage ethnicities, to use Naomi's term. As we move up the ranks within the NHS, the number of those, or the proportion, I should say, of those people reflected in the higher echelons across the NHS gets less. And that's something that we have to look at, because I think being able to promote and mentor people from these heritage ethnicities is one of the most powerful ways in which the NHS can influence both its staff widely, but also the communities that they serve and are a part of. I commend the report and the recommendations, and I trust that we will really take those steps to make a game changer, as it were, to use the terms of the LTP.
Thank you. Andrew, sorry, I've got just a plane flying over the noise. You can do. Anything else that you want to add, Andrew?
I think Lincoln summed it up brilliantly, so I've got nothing further to add. Thank you, Chair.
Okay, so can I just ask for clarification? The list of recommendations, some of them are clearly our responsibility, and some of them will be the responsibility of other organisations, so we can't really decide on their behalf. So just clarity on what the ask of governing body is around that list, Andrew.
Yeah, I think for me, Chair, it's your support that we've allocated responsibility in the right way. So we obviously took it to Lincoln's inequalities group, because I think it's important that for me, this is one of the first pieces of work that we will take forward as a system. So therefore, getting it right in terms of allocation, I think, is really important. And of course, the CCG does have a key role to play in terms of inequalities, and Lincoln's right. The inequalities agenda will drive a lot of this work. So we wanted really your views and support for whether we've allocated it in the right way, because we do need to make sure that we don't lose any of the recommendations that are in the report, because it's very rich and clearly will have an impact if we get it right.
That's great, and I think it's helpful that it's already been through the group that Lincoln chairs, those list of recommendations, and they will have considered them in detail. So I think that's reassuring. I've got three hands. I'm going to take those three hands and then go to the recommendations, if possible, please. So Judy and James, first of all.
Okay, thank you very much. Just towards the end of the list of allocation of duties, which seems very sensible responsibilities, it talks about improving staff experience and improving recruitment and progression. And it refers to provider HRs being responsible. I just didn't want us to lose the fact that we have a number of staff, and I'm wondering whether your term provider HR includes CCG HR for its own staff. I think it does, but I think some people might read the word provider and think that it doesn't. And the reason I think it's triply important, not just for all the reasons we've talked about, is when we're commissioning services, if we haven't got staff commissioning them who have this broader experience of a more diverse community, it then impacts on what we commission. So I'm getting a nod. Maybe we just need to clarify with a footnote or something.
I'll make that adjustment, Judy. A really good point. Apologies, it should say both actually, because we clearly have a big role to play.
Thank you. James.
Yeah, thank you, Paul. Andrew, you mentioned having the report available in accessible formats, and I guess that means different languages, but I'm just wondering if audio has been considered, and if not, whether the communities could be asked if something like the report in the form of a podcast might help those who perhaps struggle with reading and writing.
It has been, James, yes, definitely. It will be in all of those formats, yes.
Thank you.
Ginny.
Yeah, so I just wanted to clarify in terms of taking the recommendations forward. The Health Inequalities group that people have been referring to is largely composed of a exec lead from each of the organisations in the system. So, and the purpose of that group is to make sure that we get organisational sign off from them. So the fact that it's been through that group means that each of those providers has signed up to those recommendations and the allocation of those. And as part of the Health Inequalities work programme, we meet with those exec leads on a bi-monthly basis to go through the kind of list of things that they've committed to. So this report is one of many areas that we're covering in terms of health inequalities. So we have a process in there to monitor the uptake and the progress with each of those through those exec leads.
Thank you, Ginny. That's helpful clarification. And Alison is the last hand I've got raised.
Okay, thank you. I personally welcome this report. It's really good to read, and I like the plans for implementation. My question picks up on something that Lincoln just said, actually, in that part of the report says the NHS England have got a long-term plan to improve senior level representation from people from heritage minorities. And I wanted to just ask what our plans are to work on that, and also to remind us that Naomi challenged us this morning on our own ethnic composition as a management group and wondered what our plans were.
Yeah, thanks, Alison. I wonder if I could take the I guess the CCG aspect, and Lincoln may want to say more about perhaps the system view, but certainly you'll know, Alison, that one of the CCG objectives for us in there, and I own that, is for us to make sure that we've got a much more diverse workforce. At the moment, we're operating just below half what the Devon average is, and that's clearly not good enough. So we are putting some effort and focus in as part of the objectives to attract people from the heritage ethnicity field, and make sure that we're seen as an employer really of choice in those areas. So we are considering some events once we get back to some normal operations, things like Pride that happens in Exeter and other events, so that we're really trying to see if we can encourage people from a whole range of backgrounds to join our organisation.
Great, thank you. Nick, you sneak in with the last comment, but then I am going to have to go to the recommendations.
There you go, Chair. That was quick, wasn't it?
Okay, excellent. All right, let's so the recommendations, and I think there's probably a recommendation for the governing body to make a decision that the CCG should fulfil all of its function, all of the actions that are assigned to it, including those extended that Judy has just challenged Andrew about, and then also to provide our support and backing for the report and the actions, the wider actions of the system as a whole. So I'm going to take it by exception on that. So I'm going to ask people to raise their hands if they feel unable to support that, and otherwise, in absence of hands, I will take as an approval. And I'm really pleased to say we've got an absence of hands. So Andrew, governing body agree and approve as requested. and we look forward to seeing some of the outputs from some of those pieces of work that will no doubt get underway as a result of this review. Just on that, is there a plan to repeat at some point to make sure that we are making progress?
Yes, definitely. I think that's really key. So what we will do is, as Ginny suggests, actually, I think the Health Inequalities Group will be looking at progress, but I'm happy also to bring perhaps a report back to the governing body in terms of how we've made progress along each of the 27 recommendations, because I think it is key that we monitor those and deliver on them.
Okay. Well, let's try and do that maybe early next year, give some time to do some implementation, and it will set us know where we are going into whatever the new world looks like from next April. So thank you. If we do that, say around February time, that would be useful. Okay. Locality reports as read, but I'm just seeing if Anna has joined us, because the bit that we want to focus on is the main focus around Plymouth, and I've got that on page 157 of 187 in our packs. Anna, are you with us?
Yes, I'm here, Paul.
Brilliant, Anna. Thank you very much. So, Anna, over to you. We'll take it as read, but if you want to bring up some of those highlights, sort of a combination of the positives, but also some of the challenges that you might be facing within the Plymouth LCP at the moment.
Absolutely. So thank you, and thank you for the opportunity to do a bit of a deep dive in terms of the Plymouth LCP. I think it's important to note, so you've got a range of papers in your pack, as Paul's noted, starting at page 157. And the first paper is probably the one of most consideration. The other are the terms of reference, which I wanted to share with colleagues today. I think we should also acknowledge that whilst this faces very much the Plymouth LCP, clearly the relationship between the Plymouth LCP and the West Devon LCP is quite critical to ensure that we, where we certainly have PCNs that face both of those LCPs, that we are working in a collaborative way, making sure that we address the needs of our resident population rather than the architecture of LCPs perhaps acting as a barrier. And I think certainly the joint working that we have with locality directors, with the support of Nick and Sheila, is very keen. We're very keen to make sure that we bring that together in the round, and where there are opportunities for improvement, we do that once rather than separating that out through the LCP type arrangements. I think it's work in progress. And probably there'll be times that we won't necessarily get that as right as we would like to, but clearly how we work closely with our PCNs to ensure that we are not asking too much of them in terms of reporting to various structures is really, really key. So we're very keen to make sure that that collaboration is at the heart. Just in terms of the paper, I think probably the best place to look is the priority areas and programmes of work, and that's on page 166. Clearly, we know that the Plymouth and Western locality system is challenged often in relation to certainly urgent and emergency care. And I think what we've got in terms of the priorities and plans is a range of activity that we've collectively agreed as our 3-year ambition of change. We've heard today, both in public and private, around the ICP transformation and the procurement, and we believe that that is a key foundation to support some of the change across the system, whether that be managing urgent and emergency care demand, whether that be providing the wraparound support for our primary care networks, and really getting that focus in terms of well-being in the system to address some of the inequalities that we have in this part of the county. So the programme of work picks out a range of key areas. So there's 6. The compassionate and caring city is very much focusing around the trauma-informed agenda, how we deliver enhanced support for our carers. We know as a result of COVID that our carers have at times really struggled looking after their loved ones. So how we really provide that wraparound support across the voluntary sector, the local authority and our healthcare services is really important. Primary care, clearly, we know that we need to develop our enhanced primary care offer, how we make best use of population health management to profile our population and to provide that support to our resident population is key, along with that early identification of need so that we can ensure that we get the right support at the right time. Community empowerment, I think we've certainly seen through COVID as a city, and I know across the West Devon area this is entirely the same. We've got a real sense of community cohesion, and I think it will be really important to make sure that we continue to build on that over the coming months and years. And we've identified as a locality also our children and young people agenda. So just as a city, we've seen a 33% increase in terms of our looked after children numbers. And clearly, if we aren't providing the right sort of support as a system for our children and young people, they will become our adults of the future. So it feels as an LCP that that's a key priority area. Along with homelessness prevention, so as a city, we have a large cohort of individuals with sometimes quite chaotic lives who struggle to access services. So how we support that homelessness prevention agenda is a key strategic priority for us. And then finally, our integrated care agenda. And I'm not going to re-rehearse our conversations earlier around integrated care, but clearly this has to be our approach to how we address some of our challenges in terms of both urgency and emergency care, but also our recovery in terms of elective restoration. So I'll pause there. Absolutely happy to take any questions, but thank you for the opportunity to just share what's happening in Plymouth. Feels like, you know, we've got really good partnership working already in place, and a good foundation to be able to take forward some of the priority areas over the coming months and years.
Thank you very much, Anna. And I think it is timely that that actually we've got a Plymouth focus on this particular governing body, given the item that we had earlier and the opportunity that the ICP has to build on all of those elements that you just highlighted. I've got a couple of hands up, so let's take you together. Let's take Graham and then John.
Thank you, Chair. Thanks, Anna. That was really helpful. I hope my question isn't unfair to you, but I just wonder if you know whether the new political administration in Plymouth would recognise this plan and be signed up to it, and whether the Plymouth Plan, which you mentioned early on, is likely to be rediscovered or rewritten with perhaps new policies in it.
I'll give you a moment to work out how you answer that, Anna, but I'll take John next, then we can cover both.
Thank you, Chair. So, Anna, could you expand a little bit on your programme around community hubs and your view on their importance in all of this, in community cohesion? I'm jealous. Is really why I asked the question. Is I'm jealous, and what's the learning there about how we might spread this learning to our other localities and other LCPs?
Okay, thanks.
Okay, thanks. So Graham, in terms of your question, so the first thing I would say about Plymouth as a city is that it is not unusual for us as a city to have changes in administration. And as a council officer part-time as well as a CCG officer part-time, one of my jobs is to ensure for key strategic areas that actually both political parties are engaged. So in terms of development around the integrated care system, in terms of our conversations around the integrated care partnership, those agenda items regularly go through our scrutiny panel, which obviously is cross-party, and through the briefing of portfolio holders and shadow portfolio holders. This agenda is well understood by the previous administration and the new administration, and unfortunately the new portfolio holder under this administration was the shadow previously. So I am confident that actually the priorities as set out here will be absolutely aligned to the priorities of the new administration, because they're the right thing to do for residents in the city. And in terms of your second question around the Plymouth Plan, so we have had early engagement with the new administration, and I can again reassure colleagues that actually they are broadly supportive of the Plymouth Plan, and certainly in the agenda of health and care or health and well-being are aligned to the ambition as set out in that Plymouth Plan.
Thank you, Anna. That's really reassuring. Thank you.
Okay. And then John, in terms of your envy of our hub agenda, so and Sarah Lees might want to jump in on this as well, because it is Sarah Lees and it is our colleagues in public health that have absolutely championed and supported the wellbeing hub agenda across the city. The one thing I would say is that we have a huge advantage as a city and as a unitary authority in that actually we have we have space and we have buildings, and therefore that gives you exploitable opportunities to be brave. And I think that has helped us significantly. Clearly, also, we've done a huge amount of work around our inequalities in the city. So we've got a good population profile through all of the work that's been done through Plymouth Reports, through strategic needs assessment, and we can see clusters within our resident population whereby it would be hugely beneficial for a wellbeing type facility to sit. So we have taken buildings where we've had opportunities and we've joined that together, and I'll be honest, they're not perfect. Some of the buildings are less than beautiful, and probably could benefit from a huge amount of capital investment, but what they are is they are owned by the communities in which they sit, and that is absolutely key. So that sense of community ownership and that wraparound of that community to that building is much more important than how nice the building looks, would be my reflection. So we are really we've opened quite a few. We've still got an awful lot more to do. And I think we probably still have got work to do in the relationship between those hubs and the PCNs and how integrated and joined up they are, because we're not in the position of being able to build new buildings and bring all of that together. So by the sheer nature of that, there's still some architectural challenges in terms of how those offers work together. But it's the right thing to do, and every time we go out into the community and they say, when are we getting one? So it feels like we are, they are co-designed with the community, which is absolutely key.
Great.
Lovely, thank you, Anna.
And John, if you want to take the conversation further, then offline, if you make contact with Sarah, then I think that would be a good way to
happy to do that. Yeah.
Yeah. All right. Thanks, Sarah.
Simon, last question on this.
Yeah, thanks, Paul. So it's partly a comment for you, Anna, and a question for us as system builders. I'm very impressed with the way you've set out those very tangible indicators about things you want to change and perhaps what you want to measure as being evidence of how your integrated way of working will benefit the population. And I think as we develop in our sort of 5 local care partnerships, setting out those sorts of indicators is really, really key. But not only doing that, it's about how we then learn from each other and things that you've done which have achieved sort of benefits to those indicators over the next few months. Very much like to learn from you, find a way of us learning from you so that we can take those things not just into my locality perhaps, but into other localities as well. So how do we, as a system of clinical builders, I guess, or group of people who are building clinical systems in different parts of the county, learn from each other and actually and not sort of have to reinvent the wheel when actually we can maybe learn from something that you've very successfully delivered with your integrated way of working that we've just supported.
So I'll make a stab at this in terms of so I suppose my reflection, Simon, would be that now that we have appointed locality directors, then we should be absolutely given the action in terms of providing some glue. So there is so much happening across the system. Actually, it is, for me, I think, a responsibility around us as locality directors to be looking at how we share the best from all of our areas, because we've got some fantastic practice across the whole of Devon. We've got some areas that are doing some really innovative things which are working really well. We've got other areas that perhaps are a little bit more challenged. And my view would be say that as locality directors, we should be bringing that together so that we can then report back into governing body and other areas around how we're learning and how we're innovating together. That would be my, but I'm sure my executive colleagues might have other thoughts.
But I think you're right, Anna. We've got this, as long as the associate directors for locality directors are meeting together, as long as the clinicians across the place and the collaborative board chairs are coming together, we've got plenty of touch points. We just need to make sure that the sharing of good practice is integral in those meetings. Thank you, Anna. So from you and from Joe and from Anne and Joe and Michelle earlier, we've had a really good picture of the challenges, but also some of the real opportunities in Plymouth. So thank you for the time that you've given us today. So that draws our business as a public meeting to a close. I'm going to ask that, Drew, can we stop broadcasting, please? If you can let me know when we're no longer live.